Hi, I am Dr. Hind Mamoun Beheiry, an Associate Professor of Physiology. I am really honored to participate in the 12th Global Women Health Conference. The title of my presentation is Correlations of Complete Blood Count, Liver Enzyme, and Serum Uric Acid in Sudanese Pre-Eclamptic cases. The first slide of this presentation shows the title, which is Correlations of Complete Blood Count, Liver Enzyme, and Serum Uric Acid in Sudanese Pre-eclamptic cases. The second slide shows the outline of the presentation. Introduction, objectives, literature review, methodology, results, and conclusions. In the introduction, as you can see, it defines preeclampsia as a major cause of maternal and fetal morbidity and mortality. Preeclampsia is the second main cause of direct maternal death in Sudan, 11% in 2019. Preeclampsia is associated with major organs dysfunction, especially the kidneys. In Sudan, as a developing country, one of the predisposing factors for preeclampsia are the environmental factors, and these include the socioeconomic status, and definitely low socioeconomic status can increase the rate of preeclampsia incidence. So the objectives of our study were to assess changes in complete blood counts, including platelets, liver enzymes, and serum uric acid in preeclamptic cases compared to normal second-half pregnant and non-pregnant Sudanese women and their correlations to other biomarkers. The specific objective was to correlate complete blood counts, liver enzymes, and serum uric acid to each other and other biomarkers in preeclamptic cases. Our literature review was the anatomic changes in the kidney during pregnancy. The kidney increases by about 1 centimeter in size in pregnancy with dilatation of the calyces, the renal pelvis, and the ureters. The physiological renal changes during pregnancy include marked renal hemodynamic changes, which are obvious by the end of the first trimester. So both the effective renal plasma flow, the GFR, increased by 50%. The effective renal plasma flow in all probability increases more than the GFR. Hence, the filtration fraction is decreased during early to mid pregnancy. This increase in glomerular plasma flow may explain the increase in the GFR. Hypertensive disorders in pregnancy. Globally, hypertensive disorders are among the main causes of maternal mortality, accounting for almost 20% of maternal death. Most deaths occur in women with eclampsia and severe hypertension. These deaths are due to intracerebral hemorrhage. Preeclampsia, eclampsia, and transient hypertension are all classified under the extensive category of gestational hypertension. Nearly 30% of hypertensive disorders in pregnancy are due to chronic hypertension and 70% are due to gestational hypertension. So hypertensive disorders in pregnancy are 70% from gestational hypertension, or that is, they appear during the gestation, and 30% are due to chronic hypertension. And the overall cause of hypertensive disorders is 20% of direct maternal death. So preeclampsia, being one of the hypertensive disorders during pregnancy, it is a multi-system disorder characterized by hypertension and proteinuria. It occurs in the second half of pregnancy and is accompanied with increased rates of fetal and maternal morbidity and mortality. It affects about 5% of pregnancies, and this percent may increase in developing countries. And sometimes it may reach 10%. The syndrome is characterized by vasospasm, hemoconcentration, and ischemic changes in the placenta, kidney, liver, and brain. These complications generally occur in women with severe preeclampsia. The causative mechanisms include placental origin, immunologic origin, and genetic predisposition, among others. So, it is a multi-system disorder, affects 5 to 7% of all pregnancies. The predisposing factors are placental, immunologic, genetic, and environmental, which may interact. So the pathophysiology of preeclampsia, the pathogenesis of preeclampsia is many-sided. The genetic, immunologic, and environmental factors which interact. Preeclampsia is a two-stage disease. The first stage is asymptomatic, characterized by abnormal placental development during the first trimester. This results in placental insufficiency with the release of excessive amount of placental materials into the maternal circulation. This leads to the second symptomatic stage, which appears at 20 weeks of gestation, whereby the pregnant women develop characteristic hypertension, renal impairment, and proteinuria, and are at risk of the hemolysis, elevated liver enzyme, and low platelet, which is the HELP syndrome, eclampsia, and other end organ damage. The platelets are proved to be a major role or to play a major role in the etiopathogenesis of preeclampsia. A changes in coagulation system is established in preeclampsia and well documented. So, as you can see, the gestational hypertension constitutes, as we said, 70% of the hypertensive disorders in pregnancy, and chronic hypertension usually present prior or before the pregnancy, and it will continue after pregnancy. The symptoms and signs of preeclampsia include raised blood pressure or hypertension, proteinuria, edema in the hand, in the face, and lately, and there is a tremendous increase in weight, and at the end stages, the lady can go into and develop seizures, and this is clear eclampsia. So these are the changes which occur in normal pregnancy compared with non-pregnant and in the pre-eclamptic cases. The pre-eclamptic is shown on the right side of the presentation. The normal pregnant, there is peripheral vasodilatation, there is uteroplacental, increased uteroplacental blood flow, increased renal blood flow, increased cardiac output, and there is a drop in the blood pressure. On the other hand, the pre-eclampsia, untreated, may cause generalized vasoconstriction, drop in the uteroplacental blood flow. There is also drop in renal blood flow and increase in the cardiac output with increase in the blood pressure. So, hypertensive disorders, pregnancy-induced hypertension, or either due to chronic hypertension. The pregnancy-induced hypertension is the gestational hypertension without proteinuria or with proteinuria, and this is pre-eclampsia. The pre-eclampsia can be mild or severe, and either or can lead to eclampsia, that is with convulsions. Also, chronic hypertension can be superimposed by preeclampsia. This slide shows us the other etiological or predisposing factors for the placental insufficiency, which is the dominant feature of preeclampsia. And it starts in phase 1, which is asymptomatic. We have immunological factors such as the AT, autoimmune, antibodies, the NK cells, the genetic factors, the oxidative stress, and other factors. And this will lead to reduced perfusion in the uteroplacental axis due to the malformation of, as we know that during early pregnancy, the cytotrophoblast invade the spiral uterine arteries. In preeclampsia, this invasion is reduced with malformation in the placenta, and this definitely leads to reduced supply of blood to the fetus, and as such we will have growth restriction in the fetus with also other ischemic changes which occurs to the mother, as the placenta, which is ischemic, will release anti-angiogenic factors, and this will reduce the SLFT1 and indole genes and other mediators, and this will attack the anti-angiogenic factors will attack the endothelium in different organs such as the kidneys, the liver, the brain, and other endothelial areas. So overall is decreased. The overall is decreased uterine placental blood flow, placental release of factors, endothelial activation, dysfunction, as you can see, with decreased renal pressure, natriuresis, increased total peripheral resistance, and this will lead to hypertension. Here is also another slide which shows the malformation of the placental perfusion in the case of preeclampsia. On the left, this is in normal pregnancy. The fetal cytotrophoblast will invade the spiral arteries and will increase the diameter of these arteries and increase the blood flow to the fetus. On the other hand, there is mal-invasion. There is reduced invasion of the spiral arteries, and as such, there is reduced blood perfusion. And this ischemic placenta will release anti-angiogenic factors in the maternal blood, and that is why placenta is called toxemia of pregnancy. This is another demonstration. The methodology which we followed in our research was study design was a cross-sectional case control and hospital-based study performed during a 2-year period. The study population was the pre-eclamptic participant, included the newly discovered and or already diagnosed and followed up cases in their recent pregnancies. The control pregnant women were in their second half of pregnancy, 20 weeks of pregnancy and onwards. The non-pregnant groups was selected from the midwives and nurses of Omdurman Maternity Hospital, the female officers and trainees of Sudan Police Headquarters, and the female students of Rabat University. The inclusion criteria were pregnant women in the second half of pregnancy, and all of them, including non-pregnant, to have no history of diabetes mellitus, no history of essential hypertension or renal disease or any other chronic diseases. The exclusion criteria, those with multiple pregnancies and or have any obstetrical abnormality like placenta previa, polyhydramnios, etc. Those with abnormal thyroid function tests were also excluded. The funding, no external funding, it was self-sponsored, no conflict of interest, ethical approval from the research committee, Faculty of Medicine, International University of Africa. Permission was given from Omdurman Maternal Hospital to conduct the study for cases of preeclampsia and normal pregnant subjects. The participants' written consent was undertaken. Sample size calculated from the records of the hospital The sample selection was done by a systemic random selection every day. So 72 preeclamptic cases. The study population included 72 preeclamptic cases. The control, 96 normal pregnant and 63 non-pregnant women. Laboratory data was analyzed and used for this study. CBC, liver enzyme, serum uric acids, among others. Statistical analysis, the data is presented as means and standard deviation of the means. Correlation between quantitative data was determined using Spearman's test. The p-value was significant for less than 0.05. Our results were really amazing, and I think this has led us to further to the importance of conducting further research in this area of preeclampsia. The figure here in this slide shows the percentages of the groups among the population, as you can see. The red color is the normal pregnant, preeclamptic, the blue, and the non-pregnant, the yellow color. The percentage of egg distribution is also shown, and this shows clearly that the age group between 25 and 29 were the highest age group of pregnancy. And this decreases on either side towards the 40 to 44 age group, only 40%, and on the other hand, in the age group between 15 to 19, only to 15%. And the most are, as I said, among the 25 to 29 years of age. Here we can see in this chart the histogram of platelets count in the three groups. The platelet count was a considerable statistical significant decrease in the mean platelet count of the pre-eclamptic, 236.4 to the power of 10 to the power of 3 per cubic millimeter, compared to the non-pregnant, 322, with highly significantly p-value 0.0001, as well as that to the normal pregnant at p equals 0.003 at a value of 275. The tables here show the comparisons of the mean between the non-pregnant and preeclamptic cases, considering the hemoglobin, the platelets, the total white cell count, with the significant values mostly shown at the platelets count and to the hemoglobin between the preeclamptic and non-pregnant to 0.005. The second table is a comparisons of mean between the normal pregnant and the preeclamptic cases, as you can see. Here also the hemoglobin levels, the mean hemoglobin concentration shows limited variation in the values in the three groups. The mean hemoglobin concentration was significantly lower than that of the non-pregnant group, but not from that of the normal group. The white cell count, there was no statistical significant difference in the mean white blood cell count between the preeclamptic and neither of the other two groups. The serum alanine aminotransferase showed correlated significantly with the serum aspartate transaminase. In the preeclamptic cases, serum alanine transferase correlated significantly with the total white cell count and serum aspartate transaminase. Serum aspartate transaminase also correlated significantly with serum alanine transaminase. In the preeclamptic cases, the serum aspartate transaminase correlated significantly with the hemoglobin, with the ALT and serum uric acid. This table shows means and 25 confidence interval for the hemoglobin, platelets, systolic and diastolic Kruskal-Wallis test. It also shows significant differences in all the categories. Table 4 also shows the means and 95% confidence interval for the albumin, ALT, AST, and uric acid. And as you can see, all the values had significant differences. The correlation coefficient between the hemoglobin and the serum uric acid was not present, but signifies that no correlation between the two variables. On the other hand, statistical significance between the following variables was observed: platelets, systolic blood pressure, uric acid and serum albumin, uric acid and AST and hemoglobin. The Kendall's correlation coefficient, as you can see, as well showed very significant correlations with among the variables, the systolic, the diastolic, blood pressure, the hemoglobin, the platelets, the albumin, the ALT, the AST, and the uric acid. Conclusion: there was a considerable statistical significant decrease in mean platelets count of the pre-eclamptic compared to the non-pregnant group and to the normal pregnant. May be explained by hemodilution, whereas further decrease was due to pre-eclampsia. ALT and AST are strong prognostic indicators of pre-eclampsia. The use of hematological profiles as a screening program for pregnant women with obvious risk factors of pre-eclampsia or pregnancy-induced hypertension is confirmed. Acknowledgements is we are highly grateful to all those who volunteered to donate their blood when needed for this project and to those who helped in conduction of the study. These are our references with still more references included in the actual paper. Thank you so much for your listening and goodbye.